Hello, you guys. Welcome back to The Dose. It's me, Dr. Robin B., and I'm here with my girl, Alexandria Lightning, another health professional. She's a nurse practitioner, and she's going to tell you guys a little bit about herself.
Thank you so much, Robin, for having me on your show. Yes, my name is Alexandria Lightning. Yes, that's my real last name. And I'm actually from Indiana. Wow. So I was born and raised in Indiana. Was pre-med. I was actually pre-med when I first started off in my college journey, and then I was working alongside a lot of servers in restaurants who also were pre-med and had gotten their degrees in biology and other things, and med school didn't work out for them. And I was afraid, what if I don't get into med school? What if I change my mind and want to find something else? And so that is when I made the decision to still be pre-med but switch to nursing, because I figured at least if I change my mind, I'll have a nursing degree at the end of the day.
You could still move forward from there if you ever wanted to.
Exactly. And at that point in time, I actually had no idea what a nurse practitioner was. So it wasn't until I started my nursing program that there was this big push of, when you're done with this bachelor's degree, are you going to continue your education further to get the master's and go on to be a nurse practitioner? And that is when I learned that a nurse practitioner is an advanced practice nurse that goes for additional education beyond the 4-year bachelor's degree in order to have the privileges of diagnosing medical conditions, prescribing medications, ordering diagnostic tests and imaging, and basically providing overall care for a patient, being able to open up their own clinics, have their own patient panels, treat in many ways like a physician. And that was very enticing to me because it was kind of everything that I wanted to do as far as the realms of patient care, as far as being a provider and having patients without calculus. Without calculus.
That makes a lot of sense. I mean, it was the same thing for me between pharmacy or pre-med. Took the MCAT too. Did you end up taking it?
I did not take the MCAT.
Okay, so you didn't go that far.
I did not.
But I was like, I wanted a doctorate of some sort, but it wasn't until I actually worked in a pharmacy that I realized, okay, I can do this. And it's, the hours are more flexible. There's all these other benefits to that, but that's awesome. I wanted to know, okay, I'm even confused as far as the D, is it DNP?
Yes.
Okay, break it down for us, please. I want to know, because pharmacy, it's not that much. Either you go into residency and you work at CVS or the hospital. It's not that much of a variety of degrees you can get.
The nursing profession, that is one thing. First of all, nurses, the difference between like the nursing profession and physicians is that we go by the nursing model at all levels. Physicians and physician assistants, they go by the medical model. That's a different conversation. But to answer your question about the educational requirements, you hear the word nurse a lot, and nurse gets thrown around. But there are literally lots of different nurses that have varying degrees of privileges, and that can be very confusing. So first you have nurses from decades ago who graduated from diploma programs. I don't even think diploma programs even exist anymore. They've they've phased those out, but you do still have some older nurses that did graduate from diploma nursing school. So you have those types of nurses, and I have no idea what they were grandfathered under to be able to continue practicing. And then the next level up is that you have an LVN or an LPN, licensed vocational nurse or licensed practical nurse. Their programs are maybe 1.5 to 2 years, depending on the program. Do not quote me on this. I believe that they have it's a certificate program. I don't think it's a degreed program.
Okay.
So, and that's what they practice as. They don't have as much privileges as a registered nurse. So LVNs can't do things like start IVs. They can maintain them, but they can't be the ones to start them, and there's a few other things that they can't do that they're not certified to do. Going into the first realm of being a registered nurse is an associate's degree. So a 2-year degree, associates, and then you sit for a national certification or national boards rather, and then you get registered as a nurse. You take that exact same board or when you go and you get your bachelor's degree as well. So basically RNs, registered nurses, can either do a 2 years associates, a 4-year bachelor's, or they can get their associates first and then do a bridge program from associates to bachelor's. There's no difference in the privileges of the two.
Okay.
A lot of places there's no difference in the pay.
Yeah.
So that would beg the question, well, why would I go to school for an additional 2 years if I'm going to take the same exam,
True.
board certified, you know, the same board and not get paid more, and it's more schooling?
Years.
Well, one, research has shown that bachelor's educated nurses, when a unit is 80%, when a nursing unit at a hospital is staffed with 80% more of bachelor's educated registered nurses, morbidity, mortality, and the rate of infections decreases.
Well, that's good. That's really good.
And then if a nurse is looking to go into like a managerial mode, you know, a director of nursing or anything like that, they are requiring at least at minimum the bachelor's.
Okay.
So
there are some privileges.
There are privileges, exactly. So so that's basic. All what I just listed: the diploma nursing, the LVNs, the LPNs, the registered nurses. Nurses.
That's that.
Nurses.
Now,
they are not allowed to diagnose a patient.
Exactly.
They are not allowed to treat a patient outside of what another advanced practice provider has given them orders to do. They do have a lot of autonomy in certain regards to nursing diagnosis, which is things that you can notice about a patient, like if they're in respiratory distress, so they might need some, you know, help with that, you know, sitting them up in bed so that they can breathe better and things like that, but no medicine.
Okay.
Not allowed to go order an x-ray, not allowed to go put in a referral for a respiratory therapist without a physician or other advanced practice providers.
Wait, so pause there. So you're saying that a nurse practitioner doesn't need a physician oversighting what they're doing?
It depends on the state. So yes, right now, I'm glad you brought this up. So right now there's actually in California, legislation AB 890 just passed the Assembly, and now it has to be passed through the Senate. And that is a bill that is introducing for the ability for nurse practitioners to be able to practice to the fullest extent of their education.
Okay.
So lots of other states like Arizona, Nevada, Connecticut, just to name a few, already have this in place, where nurse practitioners can practice completely independent of a physician.
Wow.
They can open up their own practices, have their own patient panels.
See, you guys didn't know that. I bet you didn't know that.
Yes, they can order and diagnostics, prescribe medications.
Yeah.
California is a little bit different. We do have to have what they call you have to have a collaborating physician, and the name of the document that we have to have in place is called like a standardized procedures, which is just basically an outline of, while I'm working with this physician, these are the things that I can and cannot do. With that said, that does not mean that the physician actually has to be on the premises. We basically just have to have a physician
in a way?
Not even sign off.
Okay.
We just have to have that's why even in California, even though the law has not passed yet, you still have lots of nurse practitioners opening up their own practices. All they have to do is find a physician that's willing to say, yes, I will be your collaborating physician.
Okay.
And what
it's like a cosign.
Exactly.
That's awesome.
And only on 10% of I think it's only 10% of the charts that they have to co-sign off of, and it's not even right then and there.
Right. So they're just kind of saying, are you running the business smoothly? And they trust you pretty much from there.
Yeah. And then at the end of the month, they at random choose maybe 10 of your patient charts and make sure that you haven't done anything ridiculous, exactly, or crazy, and you move on.
Wow. And you know what? I think that physician has always been the, staple. Everybody understands what a doctor does, but they don't understand what a nurse does or a pharmacist does. And there's so many new bills passing, like, we have the SB 493 and 159, where we're able to administer PrEP and PEP.
Oh, nice.
Yeah, so we can, so guys, PrEP is pre-exposure prophylaxis. So that's for people who have all the risk factors of maybe getting HIV. However, they can't, they don't know that they're gonna get it, but they have all these risk factors. So they can come into us and we can prescribe them Truvada, things of that nature. And the same goes for post-exposure. So if they just had unprotected sex, they're worried about it, they can come straight to us and we can give it to them. Same goes for hormonal contraceptive, you know.
That's very surprising. That's a big deal.
Yeah, so we can furnish that as well, and Suboxone.
Okay, so so how do you guys go about doing the labs that are required to monitor the liver function and things like that?
We order them. Yep.
You send them to the lab?
Yep.
And all,
so
wow.
Especially,
this is getting intense for you guys
crazy.
too.
It's crazy. So think about it. Yeah, we can interpret and everything and order labs, but we'll call and make sure that they've had, like, we have to see it. We can't say, the patient can't tell us, yeah, I'm negative for HIV, give me the medication. We have to confirm it either in the office or we have to call and get a test ordered. So it's not as easy as that. We definitely do take like measures to make sure that they, you know, are candidates for the medication, but it's crazy. No one knows that. They just think that pharmacists do vaccinations and just furnish medication.
Oh no, I know y'all don't do that, because I've had a few of y'all. I write a prescription and the patient comes back and says, pharmacist wouldn't.
We run everything.
And I'm like, whoa, what the hell?
Because, okay, think about it. We've done 4 years of pharmacology, and not to like dumb any other profession down, but even physicians, they go through one course of pharmacology.
It's one semester too.
Yeah, it's not enough. And even with us, it's not enough, because drugs they come out. And imagine, I'm learning stuff that my professors didn't have to learn. Yeah. There's so many diabetes medications. They had like 4.
Yeah.
And there's like 40. So it's crazy.
And then things are getting recalled. Like, oh, now that this has been out for 20 years and we have additional research, this is kind of causing cancer in certain people. So we're not going to do that one anymore. So that's a lot of responsibility. That makes sense though.
Yeah.
You know, one of the things that I want to do more research in or look into is finding a way for specifically primary care offices, because that's where I work at, how we can get into better collaboration with pharmacists. We're not even there all the way when it comes to referring out to specialists, specialties, but I feel like that is missing. There needs to be a free, open dialogue and relationships between providers and pharmacies, because, for instance, vaccines. You know, lots of vaccines, especially childhood immunizations, are multiple dosages that are required, and a lot of times children and parents aren't able to bring in their children to complete that vaccine series because of time constrictions. You know, they have to be at work during doctor's office hours, so when they bring
we're the most accessible. Come to us.
Come to you. So when they bring their child in for their well child exam and they get their first dose of, say, the HPV vaccine, but they still need 1 or 2 more doses, but they can't make it, they can't take another day off work to bring them back. You know, the extended hours of the pharmacy is a perfect opportunity to do that. But we as providers don't know, we don't even know your scope. We don't know who can do it, who can't, because I know certain states don't allow that. Does California? I don't even know. Educate me.
For HPV?
Yeah.
I'm not quite sure. I don't know, but we definitely have all of those within the pharmacy, so I don't think that there's a problem if they come to us with a prescription for it. So that's another thing. So if the office is closed and you guys haven't prescribed it, then no, we can't just furnish that. But like I said, hormonal contraceptive, that's just easy, because if someone needs that, we're the first person they should go to
no way, they don't have to come to me to get birth control?
We know everything. We know how the drug interacts.
But I didn't know that they didn't have to come to me first.
No, they can. But yeah, they don't have to come first.
That's wonderful.
Yeah. We're trying to,
That's wonderful.
We have that education. Because think about it. Yes, we know about drug-drug interactions, but most of it is like physiology too. We have to learn how drug works in the body, PK parameters, like how the drug is acting. So we know all the systems in the organs and how they function, so then we can be able to prescribe the medication. So it's similar to, we have similar curriculums. Similar.
That's amazing. We definitely, this collaboration, much needed.
Woo!
Much needed. For instance, when I write certain prescriptions, I don't know like how to dispense them necessarily, because I don't know how they come, because I'm not using these medicines. Most of them that I'm writing.
So you might write like a dosage that like doesn't even exist.
Exactly. That happens or like, you know, if I have a big one, people come in for like, you know, if they're constipated, they need Miralax. I don't know, like, Is that coming in a powder? Is it coming in a liquid?
Right.
How big is the bottle?
Right.
Are they coming in individual packets?
that's
I don't
another
know.
thing.
So I just write one box and hope that, are they coming in boxes? I
Yeah.
don't know.
Exactly. And so that's the thing, because we know the OTC. We're the only ones that know the over-the-counter medication. So it's like, we see it. We go through those rows in CVS and we know it's there, and we know that Metamucil is in this big jug and you just put it in your water. Exactly.
Yeah. So it helps to know. It helps to know those types of things.
Yeah. So we definitely need to work together more. And this helps just by educating not only health professionals, but the public about who they can go to. And,
and when. Yeah, exactly.
You guys, I hope you enjoyed the video. Please comment below, like, hit subscribe, and I'll see you on the next time on The Dose.